So, Swapnesh, what is the order? We are starting with the cases or the talks?
Sir, Bide sir and Naga ma'am will give a short intro and welcome everybody. And we'll start with the long case, then the short case, and followed by two presentations by the Retina fellows from JJ.
Perfect.
And
So
long case will be long case Viva. Dr. Bafna and Dr. Ashish are going to take short case Viva. Dr. Saili will be taking. Overall moderation, Anaga madam and Bide sir are there to man the show. Quiz will be at the end. 5 questions.
So let's start. So Bhide sir, over to you.
Okay. So good evening, everybody. I want to thank Professor Padmashri Lahane sir for initiating this PG teaching activity on Zoom platform. Actually, PG teaching is our dream in this year. We are planning PG teaching every month. I want to thank Professor Ragini Parekh madam also, and Dr. Swapnesh, Dr. Preetham, Dr. Saili, and everybody from JJ Hospital and Grand Medical College. So for this month, the topic is Retina. We are going to have 2 webinars. So first will be today, and we are fortunate to start our PG activity on auspicious day of Datta Jayanti. So as Dr. Swapnesh has said, there will be 2 cases, one long case, one short case, and the vivas will be taken by examiners, followed by 2 lectures. And we are going to have a short quiz at the end of each session. And at the end of the year, we will have a leaderboard with toppers so that we can give something like maybe registration for MOSCON next year free to the topper. That way we can decide amongst ourselves and then we will finalize. So without wasting time, I think we should start with the today's lecture series. I think I request Hane sir and Ragini madam to say a few words for this activity and then we will start. So over to you, Lahane sir.
Thank you very much, both Santosh and Anaga and Swapnesh, who have started this activity. And I think PG activity online is a good idea. And also case presentation and then presentation by the Retina fellows and different topics. It's a very good idea. And Ragini has taken the initiative to start with Swapnesh, Preetham, the Ashwin and Saili. So my best wishes to the presenter and also best wishes to the who are going to present the Retina also. So we can go ahead. Ragini can speak and then we can start.
Thank you, sir. So my respect to you on Datta Jayanti, as Santosh rightly said that it is a very auspicious day to begin. Once more, I congratulate my friend Dr. Santosh for being the president of MOS and for a lovely beginning since November, and his active and humble participation and taking everybody along. Anaga is always dynamic, Vardhaman. I really thank Swapnesh for his active role in the webinars for the last 2 years and taking the lead in the Retina CME. Dr. Preetham, who is the chief of Retina in JJ, with Dr. Ashwin, Dr. Saili, Dr. Ashish. I think that JJ Retina department under Dr. Lahane's leadership and the patients that come to him for his care especially is one of the best departments, even if I do say so. And I'm proud of the way people work hard. I'm really happy that my Retina fellows and my residents, even though they came from the camp, 1100 surgeries and they were very tired, but while after assisting me for 18 hours also, Kunjal and Shilpa Deshmukh were very actively involved in preparing for this, and I think it's a very good initiative, and congratulations to MOS. Thank you, sir, for being our guide and our light, and thank you, Swapnesh, for putting all this together.
I think we should start. You take over.
Thank you, sir, for all your guidance. I would like to now request Dr. Sapnesh to start the session. Thank you to everyone for coordinating this event, and let's looking forward to a great session.
Yeah, I thank you everybody, and I request the PG student from JJ Hospital to start with her long case.
Yes, sir. Am I
Dr.
audible?
Shilpa Deshmukh, right?
Yes,
Yes, yes.
ma'am.
Yes.
So Shilpa is a third-year resident from JJ, a very hardworking, very sincere, very humble, down to earth, and all the best to Shilpa with hers and everybody's blessings.
Thank you, ma'am. Good evening, sir and ma'am, and everyone. So my case is retinal vein occlusion. A 50 years old male patient, Mr. Mahadev Agze, came with chimp complaint of diminution of vision in right eye since 6 months. Present history was patient was apparently all right 6 days back to start with complaint of diminution of vision in right eye, which was sudden in onset, painless, non-progressive in nature. There is no history of any ocular trauma, surgery. There is no history of redness of eyes. No history of black spots in front of eyes. No history of flashes of light or curtain-like sensation in front of eye. Past ocular history. History of spectacle use since 2 years. No history of any eye drops. Then past systemic history not significant. Patient has no history of any systemic illness. Personal history is there is no history of addiction or any family history is not significant. General examination. The patient is well built and nourished. Pulse rate was 80 per minute, regular rhythm and volume. BP was 130/90 millimeter mercury. All CVS, cardiovascular system, respiratory system, and CNS are within normal limits. Ocular examination. On ocular examination, patient has a normal head posture with symmetrical face and orthophoric. On anterior segment examination, right eye uncorrected visual acuity is 636 and left eye is 612. Base corrected visual acuity with glasses. Pressure was not improving more than 636 in right eye and improving to 69 in left eye. Lids, conjunctiva, cornea, both are normal in both right eye and left eye. Anterior chamber is normal depth in both eyes. Iris color pattern is normal in both eyes. Pupil is a normal size reactive to light. Lens is clear in right eye, and there is a nucleosclerosis grade 1 in left eye. IOP was 11 millimeter of mercury and 17 millimeter of mercury in left eye. On posterior segment examination, sir, this is a fundus photograph of right eye, color fundus photograph of right eye showing the normal disc, which is a 0.4 CDR with clear margin. Then these are the flame-shaped hemorrhages, which involve the superotemporal quadrant. Cotton wool spots. These are cotton wool spots involving the macula. And this is the old sclerosed vessels involving the superotemporal quadrant. So all these findings are suggestive of a superotemporal BRVO with possibility of cystoid macular edema. The left eye color fundus photograph, left eye fundus is within normal limit, having a 0.3 CDR, disc, macula, blood vessel, and periphery are within normal limit. So we perform the OCT scan of a right eye, which is a SD raster scan passing through the fovea, showing these cystic spaces, suggestive of cystoid macular edema, having a central foveal thickness of 706 micrometer, and that of right eye, which is a normal foveal contour with normal vitreoretinal surface within normal limit. So, sir, my provisional diagnosis is right eye superotemporal branch retinal vein occlusion with cystoid macular edema, and left eye within normal limit. With investigations, so this patient has an age of 58 years. So we can do 2 investigations, systemic and ocular. So hypertension is the major risk factors for BRVO. So we first measure the BP of the patient. Then the routine investigations, we can go ahead with the blood, with the complete blood count. There is a risk factor of chronic renal failure and thyroid also for branch retinal vein occlusion. So we can do renal function test and thyroid function test also. Diabetes mellitus is also risk factor. So we have to do the fasting blood sugar and postprandial blood sugar along with the CRP and ESR to rule out any inflammatory etiology for BRVO. Then the RVO profile. The patient has old age, so we should perform the RVO profile also. RVO profile include the 2 2D echo to rule out any ischemic heart disease, then carotid Doppler to rule out the carotid artery disease, and the serum homocysteine. As a serum homocysteine, hyperhomocystinemia is a risk factor for BRVO. Then thrombophilia profile. So thrombophilia profile we perform in only young patients or patients having a bilateral RVO and inflammatory diseases. Blantox test, VDRL, and ELISA. Ocular investigation involving the OCT and FFA, ocular fluid strobography and FFA. OCT I also perform. FFA is a gold standard for BRVO, but there is certain limitations for FFA. So we have to perform OCT also. Management. These are three managements for BRVO. One is the laser photocoagulation, another is intravitreal steroids, and third one is intravitreal anti-VEGF. So for my patient, which is having a 636 vision in right eye with cystoid macular edema, the possibility we can add anti-VEGF to this patient. Laser photocoagulation. There are studies, sir. Should I tell all this?
You can probably
I
just tell
can.
about the branch retinal vein occlusion study.
Yes, sir.
That will be
Branch retinal vein occlusion study was performed in 1984. The study was performed for patients having a persistent cystoid macular edema for 3 months and visual acuity less than 20/40. That study grid laser photocoagulation was effective management for visual acuity in branch retinal occlusion study. Another study was Geneva and SCORE study. Sir, Geneva study is global evaluation for global evaluation, and another is SCORE study. SCORE study standard care versus corticosteroid in retinal vein occlusion study. Standard care for CRVO patients in observation, for BRVO patient is laser, and intravitreal in SCORE study we had a intravitreal triamcinolone in 1 milligram and 4 milligram doses. So there is no difference in visual acuity for patients of standard care and BRVO with macular edema. Geneva study is global evaluation of implantable dexamethasone in patients of RVO with macular edema. There is a increase in speed of visual acuity in case of patients having a intra-implantable dexamethasone. So other study for intravitreal anti-VEGF are Bravo study, Burwell study, Brighter, Relate, and Vibrant study. Sir, in Bravo study, we have the treatment plan and observation plan. So in treatment plan, we give the 6 monthly injections of ranibizumab injections, and the 6 monthly we have to follow up that patient. So ranibizumab is superior to grid laser is the conclusion of Bravo study. In Burwell study, the intravitreal bevacizumab have a good and equal efficacy as another anti-VEGF as that of ranibizumab and other anti-VEGF. In case of Brighter study and Relate study, the Brighter study said that the intravitreal ranibizumab with add or not add laser is superior to the laser alone. And Relate study consists of two trials, sir. One is of ranibizumab dose of 0.5 and 1 milligram. Another group is of laser group. So there is no visual acuity difference in this two group in Relate study. And Vibrant study is that the conclusion of Vibrant study is that the group with aflibercept intravitreal injection has a good visual acuity and CFT improvement than the grid laser. Thank you, sir.
Request Pritam sir also to ask some questions, and you can continue. We have 5 more minutes to go for a long case.
Yeah, Khilpa, thank you for an extensive coverage. What I wanted to find out is what is the etiology of branch retinal vein occlusion? Do you know about that? That why does the vein occlusion occur?
Sir, etiology has consist of both ocular and systemic factors.
Those are risk factors. I'm asking about how does the vein get occluded?
Etiology for yes, sir. Arteriosclerotic or atherosclerotic artery causes the occlusion of vein at the AV crossing junction.
Yes, well, that is very important. So you have to look out for the AV crossing changes where it is involved. And according to that, what are the causes of macular causes of decreased vision in branch retinal vein occlusion? One of them you pointed out was the cystoid
there are
macular edema. There is any other
Yes, sir.
ways where the
Another
macula
one
can be
is
involved in vision?
yes, sir. Another is the macular hemorrhages. Third one
Okay.
is the tractional retinal detachment, and fourth is the epiretinal membrane.
And what does vein occlusion actually lead to? It leads to ischemia. So you can
Yes,
even
sir.
have loss of vision due to macular ischemia.
Yes, sir.
That is one more way. Otherwise, very well covered. I think adding the studies was a good point. And you briefly just described the outputs of them. So that was very good.
Thank you.
Anyone else wants to ask anything?
Dr. Ashish, Dr. Preetham, sir.
Kunjal, very well explained about the studies. I would like to ask you about the role of OCTA in the current management of vein occlusions.
Role of OCT. Sir, fundus fluorescence angiography is the gold standard, but we have to perform the OCT and OCTA as fundus fluorescence angiography has certain limitations. OCT delays the superior and deep capillary plexus also, while in fundus fluorescence angiography, we have to see we see only superior capillary plexus. And in OCTA, there is a qualitative and quantitative assessment of BRVO, like qualitative and quantitative assessment of non-perfusion area of capillaries, foveal avascular zone, dilated tortuous blood vessels, then microaneurysm. Only there is a drawback that we can't see the cystoid macular edema in OCTA, as there is a lipid particulate matter. We can see that hard exudates on OCTA, and hemorrhages. Intraretinal hemorrhages, where they are located, whether they are beneath the deep capillary plexus or superficial capillary plexus.
Yes, very good. So OCTA basically we use for prognosticating in branch retinal vein occlusion to see mainly the macular issue, also the deep capillary plexus, as you rightly pointed out about sir was saying about ischemia. So ischemia very well be seen in OCTA, which is not very well seen
in fundus fluorescence angiography.
Very nice. Okay. Preetham sir.
I think you've covered all the points very nicely. Just one thing which has to be remembered is you spoke about the BVO study.
Yes, sir.
This was a landmark study. You spoke about the aims and objectives. One recommendation which the branch vein occlusion study gave is that in the acute phase, in the acute phase of branch vein occlusion, when you have so many hemorrhages, FFA doesn't really throw light because FFA causes a lot of block fluorescence.
Yes, sir.
Okay, so but nowadays we have OCT angiography. So OCT angiography works on the principle of Doppler. So OCT angiography can show you the perfusion even in the acute phases. But FFA fundus fluorescence angiography is something which will not do in the early phases, early immediate acute phase of branch vein occlusion. In acute phase, what will guide your treatment is OCT, the visual acuity. These are the things which will guide your treatment. The other thing is during the branch vein occlusion study was almost three decades ago. During that time, there were no anti-VEGFs. So there was a recommendation of doing grid laser photocoagulation. But nowadays, grid laser photocoagulation has taken a back seat because studies like Bravo study, have proved that giving anti-VEGF injections, branch vein occlusion, the prognosis is quite good, provided there is good macular perfusion, provided there is no macular ischemia.
Yes, sir.
So these are some of the points we have to remember in the management. Also, one has to remember that when it goes into the neovascular phase, then what is the treatment, Shilpa?
Sectoral laser, sir.
Sectoral laser, right? Suppose if you don't do sectoral laser, then what are the sequelae?
Neovascularization, sir, VH patient in 20% cases, neovascularization develop.
It'll end up with
20%, 60% develop vitreous hemorrhage.
Besides, what else? Vitreous hemorrhage, and what else can happen?
For neovascularization, tractional retinal detachment, sir,
Yes.
after epiretinal membrane.
Yes.
And
finally,
neovascular glaucoma in very rare, 3%.
No, neovascular glaucoma is rare. No, that is more common in central retinal vein occlusion. You said vitreous hemorrhage, you said tractional retinal detachment. And what is the final thing that can happen because of too much traction?
Fractional.
Combined retinal detachment.
Combined retinal detachment. Red matter.
Because the retina is ischemic, it is friable. So in BRV or tractional retinal detachment leads very easily to a combined retinal
Combined.
detachment,
Okay.
right?
Yes, sir.
Chalo, good, nice.
Thank you.
Request Shilpa to stop share, and Kunjal can start her case, a short case, and Dr. Saili would be taking the viva.
Thank you, sir.
Kunjal, you can share your slides.
Yes, good evening, sir. 2 seconds. Good evening, sir and madam, and good evening, everyone else. So I'm doing a short case presentation on CNEM. A 74-year-old male, Mr. Gulabrao Dhanavade, came with the chief complaint of gradual, painless, and progressive diminution of vision in both eyes since 2 years. Patient was apparently all right 2 years back when he started developing diminution of far vision, which was gradual in onset, progressive, and painless in nature. There is no history of any ocular trauma. There is no history of any recurrent redness, no history of fever, no history of putting any eye drops. Patient has a past history of right cataract surgery done elsewhere 3 years back. Patient has a history of left eye cataract surgery done elsewhere 2 years back. Patient has a history of taking anti-VEGF injection in right eye twice elsewhere. Patient has a history of taking anti-VEGF injection in left eye taken twice elsewhere and taken in October 2022 in JJH. Personal history. Patient has a history of spectacle wounds since the past few years. Patient is a known case of diabetes since 15 years and is on treatment for the same. Patient is also a known case of hypertension since 15 years and is on treatment for the same. Patient has a history of angiography done twice in 2018 and 19 and is on blood thinner since then. Patient has no significant family ocular history. On general examination, the patient was well built and nourished. The pulse rate was 80 beats per minute. It was regular in rhythm and water.
Kunjal?
Yes,
Okay, this is Dr.
Yes, ma'am.
Saini. So at the end of the history, I would like to ask you, what are the causes for gradual progressive painless loss of vision, which your patient's main complaint is?
Ma'am, there are many different causes for gradual painless progressive loss of vision. One of the most common is refractive errors. There can be cataract, open angle glaucomas. Patient may have, since the patient is a diabetic and hypertensive, he can have diabetic retinopathy, hypertensive retinopathy, which are other causes of gradual painless progressive loss of vision. Other rarer causes are corneal dystrophies, which can also cause gradual painless progressive loss of vision. And one of the main causes in older age groups, since the patient is 72 years of age, it can be age-related macular degeneration, which can cause gradual painless progressive loss of vision.
Anything else you would like to ask in a patient for personal history if you're considering age-related macular degeneration as one of the differential diagnoses?
Ma'am, we can ask about the history of any addictions like smoking and alcohol intake, because it is one of the main risk factors for ARMD.
Okay, fine. Go ahead with your examination.
Yes, thank you, ma'am. On ocular examination, the patient had normal head posture, a symmetrical face. The patient was orthophoric. On anterior segment examination, the best corrected visual acuity in right eye was finger counting 1 meter. The rest of the anterior segment in the right eye was within normal limit, and the patient had the posterior capsular IOL. In the left eye, the best corrected visual acuity was finger counting 1.5 meter. The patient had, other than that, the anterior segment was within normal limits. On the fundus examination, posterior segment examination of the right eye, as we can see, it is a colored fundus photograph. The patient had a normal disc. It was 0.3 CDR. The blood vessels were normal. When we see at the macula, there's a large lacy white lesion at the macula with hyperpigmentation at periphery. Most probable cause can be a choroidal neovascular membrane. Other than that, the peripheral retina was normal. In the left eye, I have done a comparative picture. The patient has taken one anti-VEGF injection in JJ. So before, when the patient came to us first, this was the picture. As you can see, the patient has a yellowish white lesion at the macula, and there is also a hemorrhage present at the macula. Post injection, the hemorrhage was gone. On the OCT finding in the right eye, which he has taken anti-VEGF injection elsewhere twice, 1 year back. The vitreoretinal junction was intact. The foveal contour, it was disturbed. There was a hyper-reflective subretinal membrane visualized, but there was no evidence of any SRF or any intraretinal fluid.
which can suggest that it is already a scarred CNVM. In the left eye, before giving anti-VEGF injection, this was the picture. The patient had intraretinal fluid. There was also presence of subretinal fluid, and along with that, there was also a hyperreflective membrane. After giving the injection, this is the post-injection photo in which you can see there is the vitreoretinal junction was intact. The foveal contour, it was disturbed. There was a hyperreflective subretinal membrane present, which is the coronal neovascular membrane. However, after the injection, the intraretinal fluid as well as the subretinal fluid was markedly decreased. My diagnosis for this patient, provisional diagnosis would be a 70-year-old male, a known case of diabetic hypertensive on treatment, with both eyes scarred CNVM at present, which is status post anti-VEGF injection, which he has taken. I would like to investigate the patient. I would like to do a complete blood investigation. I would also like to do an ECG because he has a history of angiography. I would like to do serum lipid profile, as serum lipid levels are one of the risk factor. If the patient is high cholesterol, it is one of the risk factor for ARMD. In ocular investigation, I would like to do the vision and refraction of the patient. I would like, as I have done the fundus and OCT already. Other than that, I would have loved to do a fluorescent angiography, and I would like to do an indocyanine green angiography for this patient.
So,
yes, ma'am.
Okay. So the investigations which you have written, why do you want to do a complete blood investigation for this patient?
Ma'am, I would just more than blood, complete blood. I would like to do a sugar level, fasting PP level, as
why would you do the fasting PP of this patient? Because at present the patient has scarred CNVM in both the eyes. So what is your treatment right now? What treatment you are planning for this
right
patient?
now? I would not like to give any injection to this patient.
So why are you planning a blood investigation and ECG and all those?
This should have been before. It was before giving the injection.
Okay, and what is the role of ICG angiography in this patient? You said you would like to do ICG angiography. So which are the cases where you do actually do indocyanine green angiography? All the
if you want to rule out the presence of PCV, that is when we are suspecting a polypoidal choroidal vascularization. That is when we would like to do an ICGA to differentiate between that and CNVM.
Okay, so
not in this case. Yeah, I would not like to do it in this case.
Clinical examination, how does the polyp appear?
On clinical examination, it is again on a fundus examination, it is very similar to a drusense because it shows yellowish white lesions, which are many small yellowish white lesions are seen around the macula.
Is it yellowish white? Okay. So you see actually the polyps which are orangish in color, and they could be peripapillary, and there will be dilated choroidal vessels or it could be at the macula as well. Okay, the vessels of the choroid, they appear dilated.
Yes.
So this is how the polyp appears, and in this case it doesn't look like a polyp, so there is no role of ICG. FFA can be done to identify which type of CNVM is it before it gets scarred. So in a scarred CNVM, actually FFA also doesn't have any role.
Yes.
Okay. Next slide.
Ma'am, for management, as this case already has both as scarred CNVM, there is no active management required as such. In other than this, if there was a dry ARMD, we would have gone for vitamin supplements and high-dose antioxidant therapy to reduce the further progression.
So which study has recommended antioxidant treatment for dry age-related macular degeneration?
Yes, ma'am, there's a study called the age-related eye disease study, AREDS. There are two parts, part 1 and part 2. In part 1 of the study is when they have suggested giving high-dose antioxidant and vitamin therapy, which includes vitamin C, vitamin E, beta-carotene, zinc oxide, and cupric oxide. But later it was found out that beta-carotene can cause lung cancer in patients who are on the higher smoking side, which is one of the risk factors. So in AREDS2, they suggested that instead of beta carotene, we can give other forms of carotene, which are lutein and zeaxanthin, which can reduce the risk of lung cancer as well as help with decreasing the progression of ARMD.
So what is the dose of lutein and zeaxanthin which was recommended by AREDS2?
Dose of
Lutein and zeaxanthin.
I think 10 microgram and 2 mg.
And
2 mg, ma'am.
okay. So how was the age-related macular degeneration classified by ERIT study?
Hello.
Hello, can you hear me?
Yes, ma'am. Yes, ma'am. There are 4 categories in which we can divide the ARMD. Firstly, there is no age-related changes present, in which it can either have very small drusen which are less than 63 microns, and there is no other RPE changes, hyperpigmentation or hypopigmentation present. Then there is a mild form of ARMD in which there are drusens which are more than 63 microns in size, but there will not be any other RP changes like hyper or hypopigmentation. Then there's an intermediate form of ARMD in which there are larger intermediate drusens, which means 63 microns to 125 microns in that range, or there can be a larger drusen of one large drusen of more than 125 mg. The patient might also have geographical atrophy in either of the eye, or they can have here. And then there are advanced type of ARMD in which along with this there can be geographical atrophy in the region of the macula, in the region of the fovea, or else there can be neovascularization.
So what are the causes of
Hello.
What are the different causes of choroidal neovascular membrane?
Choroidal neovascular membrane. There can be other causes like choroidal rupture, which can cause choroidal neovascular membrane. There can be other causes like choroiditis, recurrent choroiditis, or hello.
Hello, I can hear you.
Yes. Angioid streaks is another cause.
Okay.
Pathological myopia is another cause. There can be Best disease, cone dystrophy.
Cone dystrophy.
Hello.
Okay,
Kylie,
so,
we have a minute left.
okay, how will you treat CNVM?
Ma'am, for CNVM, the main treatment protocol right now followed is anti-VEGF injections. There are different type of anti-VEGF which we can use. One of them is bevacizumab, which is actually a off-paper anti-VEGF which we prescribe. It is actually FDA approved only for colorectal carcinomas, but it has been shown that it has a very similar effect to that of ranibizumab, which is a FDA approved anti-VEGF.
Which study showed that bevacizumab is the effect is similar to ranibizumab? Which was the trial?
There are 2 studies. There was a CAT trial, comparative study, and there was an EVAN trial, IVAN trial, which showed that inhibiting VEGF in cases of age-related macular degeneration, neovascularization, which showed that it had almost the same effect as that of ranibizumab. Other than that, there is a more better drug, which is aflibercept, which is Elia, which can be used, but it is not that cost effective because it is costlier. But if we compare all the 3, it has the most greatest affinity towards anti VEGF A and B both. So it is a better drug which can be given, only that it is not that cost effective. So we go for bevacizumab or ranibizumab.
Okay.
Other than this, ma'am, there is a photodynamic therapy which can be given, which can be given along with anti-VEGF or on its own with verteporfin, but it is not preferred as compared to anti-VEGF as of now.
Good.
Okay. So, Dr. Saili, that was an excellent Viva session conducted by you. As a student, I was having palpitations hearing your questions, but perfect questions and very well answered also.
Thank you.
Preetham sir, your take on this, and then we move on to the didactic lectures by the Retina Fellows. And Dr. Nehal Mehta would be sharing a slide for diabetic retinopathy basics. Preetham sir.
Yeah, no, I think Saili has covered most of the things, so there's nothing really left to add, I think.
Okay, so
Let's go.
sir, should we move on to the PPT?
Yes, please. Yes.
Yeah, Dr. Nehal, can you share your slide? Preetham sir, we can take this opportunity to highlight the Retina Fellowship at JJ briefly before she starts.
So we have a fellowship now, which is almost 6 years old. It is a MUHS recognized fellowship, and it's a 1 year fellowship. It's a vitreoretina, medical retina, and surgical retina combined fellowship. And every year we take 2 candidates, and I think we have learned over the years how to modify the program and the curriculum as per the needs of the fellows. So it's been quite a good experience for both the teachers and the fellows.
Great. And Nehal, we can start whenever you are ready.
Good evening, everyone. I'm Dr. Nehal Mehta. I'll be speaking about diabetic retinopathy. Diabetic retinopathy is a microangiopathy that is a result of abnormal intracellular metabolism of sorbitol, leading to loss of endothelial pericytes. A disrupted blood retinal barrier leads to macular edema, and chronic ischemia results in increased secretion of vascular endothelial growth factor, which is followed by proliferative changes, vitreous hemorrhage, tractional retinal detachment, and neovascular glaucoma. Microaneurysms are a result of loss of pericytes in capillary wall and are the earliest signs of diabetic retinopathy. They look similar to dot hemorrhages and appear hyperfluorescent on FFA. Dot and blot hemorrhages are located within the deep capillary. Dot and blot hemorrhages are located within the deep capillary layer of retina, within the inner nuclear and outer plexiform layer. Hard exudates develop at junction of normal and edematous retina. They are composed of lipoprotein and lipid-filled macrophages located mainly within the outer plexiform layer. They are associated with hyperlipidemia and appear as waxy yellow lesions with distinct margins. When leakage ceases, the exudates absorb spontaneously over a period of months. They appear hyperfluorescent on FFA. Cotton wool spots refer to neuronal debris within the nerve fiber layer from ischemic disruption of nerve axons. They appear as small, fluffy, whitish superficial lesions that obscure underlying blood vessels. Venous changes that may be seen in diabetic retinopathy include generalized dilatation and tortuosity, looping, beading, which is focal narrowing and dilatation, and sausage-like segmentation. Extent of changes can reflect the likelihood of disease progression. Intraretinal microvascular abnormalities are arteriolar venular shunts. They are often seen adjacent to marked areas of marked capillary hypoperfusion as fine, irregular, red intraretinal lines that run from arterioles to venules without crossing major blood vessels. Diffuse retinal edema is caused by extensive capillary leakage and localized edema by focal leakage from microaneurysms and dilated capillary segments. The fluid is initially located between the outer plexiform and inner nuclear layers. Later, it may also involve other layers. Cystoid macular edema is detectable on OCT, and flower pattern petal may be seen on FFA. Clinically significant macular edema is defined by ETDRS as retinal thickening within 500 micrometers of center of macula, exudates within 500 micrometers of center of macula if associated with retinal thickening. The thickening itself may be outside the 500 microns. Retinal thickening one disc area, which is 1500 microns or larger, any part of which is within one disc diameter of center of macula. OCT classification of diabetic macular edema includes spongiform or diffuse edema, cystic edema, posterior hyaloid traction, serous neurosensory detachment, and tractional retinal detachment. Classified non-proliferative diabetic retinopathy as mild, moderate, severe, and very severe. Mild NPDR includes microaneurysms, retinal hemorrhages, exudates, cotton wool spots, less than the criteria for moderate NPDR, and need to be reviewed within 6 to 12 months. Moderate NPDR shows severe retinal hemorrhages, significant venous bleeding in a single quadrant over and above the findings of mild NPDR and should be reviewed in 6 months. They have a risk of progression to PDR in up to 26%. Severe NPDR is classified based on the 4-2-1 rule. One or more severe hemorrhages in all significant venous bleeding in 2 or more quadrants, moderate mass in 1 or more quadrant. NPDR is classified as 2 or more of the above criteria. Proliferative diabetic retinopathy is defined in ETDRS as mild to moderate and high risk PDR. Mild to moderate PDR includes new vessels on disc or new vessels elsewhere. Extent insufficient to meet high risk criteria. High risk PDR includes new vessels on disc greater than ETDRS standard photograph 10A, which is about 1/3 disc area. Any NVD within vitreous hemorrhage with a vitreous hemorrhage, and NV greater than half disc area with vitreous hemorrhage. Treatment of PDR should be a pan-retinal photocoagulation done as early as possible. Pan-retinal photocoagulation is the laser treatment of proliferative diabetic retinopathy, also referred to as scattered pan-retinal photocoagulation. The diabetic retinopathy study established characteristics of high-risk proliferative disease and demonstrated that there is benefit of pan-retinal photocoagulation. For instance, severe NVD without hemorrhage carries a 26% risk of visual loss at 2 years, that is reduced to 9% with PRP. Laser parameters that we usually take with a pan fundoscopic type lens, the actual retinal spot diameter is twice that selected on laser user interface. 200 microns is typically selected for PRP, equating to 400 microns actual retinal diameter. Thus, relative magnification is factored in. Multi-spot strategies available on some machines utilize a combination of short pulse duration, that is 20 milliseconds, very short intervals, and pre-programmed delivery arrays to facilitate the application of large number of pulses in a short period. Burns should be separated by 1 to 1.5 burn widths. Treatment is generally restricted to area outside the temporal macular vascular arcades. Many practitioners leave 2 disc diameters. Hello?
Continue. Please continue.
Okay. Many practitioners leave 2 disc diameters nasal to the side of the disc to preserve paracentral field. In very severe PDR, it is advisable to treat the inferior fundus first, since any vitreous hemorrhage will gravitate inferiorly and obscure this area, precluding further treatment. Areas of retroretinal traction should be avoided. VEGF use in PDR can include attempted resolution of persistent vitreous hemorrhage with a prior B-scan ultrasonography to exclude retinal detachment, with aim of avoiding vitrectomy and to reduce chance of intraoperative bleeding before a tractional RD surgery. Vitrectomy in diabetic retinopathy is typically combined with extensive endolaser PRP. Severe persistent vitreous hemorrhage that precludes adequate PRP is the most common indication. In the absence of rubeosis iridis, vitrectomy has traditionally been considered within 3 months of initial vitreous hemorrhage in type 1 diabetics and in most cases of bilateral hemorrhage. However, outcome may be better with earlier surgery, and availability of intravitreal anti-VEGF therapy may further modify the approach. Progressive tractional RD, threatening or involving the macula, must be treated without delay. However, extramacular tractional detachments may be observed. They often remain stationary for prolonged periods. Combined tractional and rhegmatogenous RD should be treated urgently. Premacular retrohyaloid hemorrhage, if dense and persistent, should be considered for early vitrectomy, because if untreated, internal limiting membrane or posterior hyaloid face may serve as scaffold for subsequent fibrovascular proliferation and consequent tractional macular detachment or macular epiretinal membrane formation. Until recently, laser photocoagulation was the mainstay of treatment for diabetic macular edema, reducing the risk of visual loss by 50% overall compared with observation. But availability of newer modalities has altered this approach dramatically. We had focal, grid, and subthreshold micropulse diode laser available with us. Nowadays, we treat with anti-VEGF agents. Following these clinical studies, which showed that anti-VEGF agents are superior to simple laser therapy, or combined with laser also they can be used. Intravitreal triamcinolone has been shown to be of benefit in pseudophakic eyes, where the steroid injection could cause elevation of intraocular pressure. In phakic eyes, we avoid it because of risk of cataract development. Pars plana vitrectomy may be indicated when macular edema is associated with tangential traction from a thickened and taut posterior hyaloid. It has also been suggested that some eyes with taut posterior hyaloid may benefit from vitrectomy. We have many anti-VEGF agents available with us, including bevacizumab, ranibizumab, aflibercept, and brolucizumab, out of which bevacizumab, ranibizumab, and aflibercept have been studied in use for diabetic retinopathy, with a dose of bevacizumab being 1.25 milligram, ranibizumab being 0.5 milligram, and aflibercept being 2 milligram. Different trials have given us the treatment protocols that we follow today for diabetic retinopathy treatment.
Nehal, can we wind up? Last 1 or 2 minutes for you. Can you just go a bit fast?
Yes, sir. Different trials that have set protocols include the Wisconsin epidemiological study of diabetic retinopathy that showed the duration and intensity of diabetes is what is responsible for frequency and severity of retinopathy. The DCCT or diabetic control and complications trial showed that intensive therapy delays onset and slows the progression of the disease. The UPDS shows that intensive blood glucose control and tight blood pressure control reduce the risk of diabetic complications, greatest effect being on microvascular complications. The diabetic retinopathy study has shown us that photocoagulation reduced the risk of severe visual loss by 50% compared with no treatment. The ETDRS or early treatment of diabetic retinopathy study has shown us that scattered treatment should be considered in severe NPDR or early PDR and should be performed without delay for high-risk PDR cases. Focal photocoagulation is recommended for eyes with CSME. The diabetic retinopathy vitrectomy study has shown that early vitrectomy provided a greater chance of prompt recovery of visual acuity, especially in type 1 diabetics and if vision is poor in the fellow eye. The DRCR.net or Diabetic Retinopathy Clinical Research Network is a collaborative network dedicated to facilitating multi-center trials for this. And these are the latest ones. Protocol H has shown us that intravitreal bevacizumab is useful for reducing diabetic macular edema. Protocol I has shown us 0.5 milligram ranibizumab or 4 milligram triamcinolone combined with focal or grid laser compared with focal or grid laser alone. There is better effect of ranibizumab and triamcinolone, obviously keeping in mind that triamcinolone should be used only in pseudophakic patients. Protocol J has shown us that the addition of IVTA or ranibizumab injections in eyes receiving laser photocoagulation for DME and PRP is associated with better visual acuity and decreased DME by 14 weeks. Protocol A has shown us that laser photocoagulation techniques for treatment of DME, in which the modified early treatment of diabetic retinopathy study technique is better than mild macular grid laser technique. There are multiple other protocols of slightly less importance, including Protocol C showing a diurnal variation in OCT, Protocol E showing that the peribulbar triamcinolone acetonide is not of much efficacy, and Protocol B showing that laser photocoagulation of DME was more effective and fewer side effects than IVTA. Protocol D was for vitrectomy of diabetic retinopathy. In cases with epiretinal membrane, it showed that the results were favorable. Protocol G showed 1/4 and 1/2 of eyes with subclinical DME within 2 years of treatment slowly on their own once we have intervened. Protocol K shows the course of response to focal photocoagulation for DME, and Protocol F shows that single sitting versus 4 sitting panretinal photocoagulation, there weren't that many differences on OCT thickness. READ 2 was done for showing the efficacy of ranibizumab in diabetic macular edema. RIDE and RISE also showed us that ranibizumab is helpful and improved vision and reduced risk of further visual loss in these cases. A RESOLVE study again showed ranibizumab was effective in improving BCVA as well as resolving the DME. Restore study showed monotherapy and combined laser therapy with ranibizumab. It showed superior visual acuity over laser alone. Bold study was done to support the use of bevacizumab in patients with center-involving CSME without advanced macular ischemia. Da Vinci study was done for VEGF trap. It produced statistically significant, clinically relevant improvement in BCVA compared with macular laser in DME. FAME study showed that improved BCVA over 2 years and risk to benefit ratio superior to low dose insert of the fluocinolide, but it was not a good thing for patients who were phakic because of cataract, and there was also development of glaucoma. Vista DME study showed benefits over the laser group in cases treated with VEGF trap. Thank you.
Thank you, Nehal. Preetham sir, your comments.
I think that's a very good overview of diabetic retinopathy. Very well done.
Thank you, sir.
You've covered most of the things actually.
Yes. Sir, should we, for the paucity of time, should we move on to the next topic? That is also very important, retinal detachment.
Let's do that. And then
yes.
Probably at the end of it, maybe we can have some comments.
Yes. So Sheetal has already shared her slides. And thank you, Sheetal. She has done the logistic work and helping to coordinate this CME. Thank you very much. You can start your talk.
Thank you, sir. I'm Dr. Sheetal Bajoria. I'll be presenting on retinal detachment types and principles of management. First of all, it's my honor to share screen with all my teachers here. I'm blessed to have you all. So, what is retinal detachment?
Ma'am, can you put it in presentation mode? Doctor, can you put it in presentation mode?
So, 1 second.
Bottom right next to the bar. No, bottom right में आप इसको मैक्सिमाइज करके बॉटम राइट पे एक बार आ जाए या व्यू में जाके स्लाइड शो चालू कर सकते हैं. मैम बॉटम राइट द कर्सर के बाद में जो टीवी टाइप आइकन है.
Actually, I can't see.
आप ऊपर बार को जो येलो बार जो है उसको क्लोज कर दीजिए एक बार ऊपर. यू शुड बी एबल टू जस्ट क्लिक ऑन द राइट हैंड साइड, जस्ट क्रॉस पे क्लिक कर दीजिए. नीचे लेफ्ट इसके बाजू में मैम लेफ्ट हैंड साइड पे इसके साथ या
Yes.
Yeah, ma'am.
Yes. So, what is retinal detachment? It is separation of neurosensory retina from RPE by accumulation of subretinal fluid. So, types of RD. First is regmatogenous RD, and others are non-regmatogenous, that is tractional RD and exudative RD. Third is combined RD, which includes both traction as well as breaks, regma. So, regmatogenous RD, in Greek, regma means rent or fissure or break. So, the three main prerequisites for RRD are: first is presence of retinal break. Second, liquefaction of the vitreous jelly. Third is traction at the break. So here we can see there is a large HST with flap, that is a break, and collection of subretinal fluid. So predisposing factors in pathogenesis of RRD. 40% of RRD occurs in myopic eyes. The risk factors are presence of PVD, history of trauma, peripheral predisposing retinal lesions like lattice, retinochoroidal coloboma. So symptoms, patient will come to you with symptoms of flashes of photopsia, floaters, field effect like seeing button-like sensation in front of eye. Signs, there will be RAPT, low IOP, mild iritis, tobacco dust-like pigments in the anterior chamber, convex shape configuration of the RD, and retinal break. Now, one condition where IOP will be high and there will be RD is called short syndrome. So basically here, the photoreceptor blocks the trabecular meshwork leading to rise in IOP. So patient will have open angle. Next is TRD. Here there will be RD, but with presence without break. There will be traction of the vitreoretinal membranes causing the retinal detachment. So VR traction can be tangential, anterior, posterior, or bridging traction. Main causes of TRD are uncontrolled diabetes, that is a proliferative diabetic retinopathy, or advanced stage of ROP, and penetrating posterior segment trauma. Symptoms will be similar, but only thing floaters will be absent in this. Signs, it will have concave configuration, retinal mobility will be reduced, and if along with break, then it is called combined RD. Exudative RD is characterized by accumulation of SRF, but here there will be no break or end traction. There will be no break and no traction. Signs, it will have convex shape configuration and shifting fluid. Now, causes you can remember as vascular, inflammatory, and neoplastic. So, vascular is choroidal neovascularization, hypertensive choroidopathy, as in toxemia of pregnancy. Inflammatory causes could be VKH, Haradas disease, posterior scleritis, idiopathic such as uveal effusion syndrome, or bullous CSR. Neovascular causes include choroidal tumors like melanoma, hemangioma, and metastasis. So, what keeps the retina attached? Active mechanisms and passive mechanisms. Active mechanism includes RP cell pump, RP cell sheath contractile action, hydraulic drag of IOP. Passive mechanisms include mechanical interdigitation of the photoreceptors, the photoreceptor matrix, acid mucopolysaccharides, the hydrostatic and osmotic pressure, mainly the vitreous gel, which impedes the fluid movement. Then why does RD occurs? The main causes are vitreous traction, retinal breaks, choroidal leakage, and mainly metabolic failure of the RP pump. So general principles of management. So my first point is you find the break and then seal the break. Second principle is approximation of the neurosensory retina with RP. So you go either out to in, that is eyeball to retina by using scleral buckle, or second is in to out, that is retina to eyeball, where you will do vitrectomy, SRF drainage, elimination of traction, and using an intraocular tamponade. So types of surgery, it include scleral buckling, cryotherapy, pneumoretinopexy, vitrectomy, and internal tamper. Now I'll be explaining about detection of break. You need to check the entire fundus periphery, indent, and see, locate the break. We can use Dr. Linkoff's rule, Dr. Harvey Linkoff given Linkoff's rule. It has 6 points. First is, if there is shallow inferior RD with SRF higher on the temporal side, as you can see here, the SRF is higher on the temporal side, then primary break is on that side, that is the temporal side. In inferior RD with equal fluid levels, the primary break will be at 6 o'clock. Well, if there is bullous inferior RD, the primary break lies above the horizontal meridian. Fourth is, if primary break is in superior nasal quadrant, then SRF will revolve around the disc and it will rise on the temporal side till it is at the level with the break. Fifth is subtotal RD with superior wedge of attached retina. This is the superior wedge attached retina. Primary break is in the periphery near the highest border. Sixth is the SRF. In cases where SRF crosses the vertical midline, the primary break is near 12 o'clock. So pre-op consideration when patient comes to us in explaining the prognosis, first is duration of the macular involvement and height of macular detachment. So if macula is not involved, or if it is involved, the duration has passed only 10 days or less than that, then there will be good post-op vision. The prognosis will be good. While in macula of RD over 2 months or old RD cases, the visual acuity will be poor post-surgery. Height of macular detachment, the photoreceptor cell degeneration is more severe with increasing separation from RP. The choice of technique, the closure of break is called retinopexy, that is sterile adhesive chorioretinitis. You can use either cryopexy, diathermy, or photocoagulation. And now cryopexy is based on Joule-Thomson principle, where freezing and thawing technique is used. Advantages: no damage to conjunctiva, sclera, or vitreous, no anterior segment ischemia, no rise in IOP. Disadvantages: there is high risk of PVR changes, choroidal effusion, CME, and exudative RD. Photocoagulation is based on the principle that light energy is converted to heat energy. It basically, the light is absorbed by the target tissue, its temperature rises, and there is coagulation of proteins. So the modes of delivery are slit lamp. You can use slit lamp laser, endo laser, or transcleral mode. Advantages: posterior application in case of posterior break, and it is also more accurate. Disadvantages are peripheral breaks in hazy media, where you can actually use cryo, and it is not effective in presence of SRF. It won't, the laser marks won't be manifested. Damage, there is risk of damage to cornea, iris, lens, and fovea, and also hemorrhage, effusion, and exudative RT. Diathermy, it uses 13.56 megahertz radio frequency. Use is restricted. Mainly, there are two uses of diathermy. First is hemostasis, coagulate the bleeders. Second is to locate the mark the location of the break before SRF drainage and before FG. Advantages: there is no pigment fallout and early adhesion. Disadvantages: dry field, IOP elevation, risk of choroidal hemorrhage, and perforation through thin sclera. Chemical coagulation, you can use chemicals like mercuric chloride or cyanoacrylate glue to close the break. Subretinal fluid drainage. Effects is mainly it reduces the intraocular volume and permits more buckling effect and space for intraocular tamponade. Different procedures can be used. One is pneumatic retinopexy. Here it is mainly used in, it's a OPD procedure where used in macular and other posterior retinal breaks. Redetachment after scleral buckle, isolated tear under superior rectus, or filtering surgery if anticipated. I'll be little rushing fast. Complications here. First, we cryo the break and then gas is injected. And once the gas has sealed the break, the retina appears flat. So complications of pneumoretinopexy, there could be fish egg appearance of the bubble, gas entrapment, then iatrogenic macular detachment, risk of re-RD, and fibrinous reaction around the gas bubble. Vitrectomy. Indications of vitrectomy. In rhegmatogenous RD, mainly in which retinal breaks cannot be visualized, like vitreous hemorrhage, vitreous debris, PCO, IOL edge effect, in which retinal breaks cannot be closed by buccal, and also in cases with GRT, posterior break, and with PVR changes. Especially TRD in diabetic TRD involving or threatening macula, and in combined RD, penetrating injury and presence of epiretinal membrane, we need pars plana vitrectomy. So technique of pars plana vitrectomy, you can use either 23 gauge or 25 gauge trocar. 3 scleral ports are made around 3.5 mm behind the limbus based on the condition, whether it is pseudophakic, phakic, or aphakic. So 3 ports are made. First is infero-temporally. Other 2 are made at 10 and 2 o'clock position. Through the infero-temporal port, we place the infusion cannula. And through the other 2 ports, we use cutter and fiber optic endolite. And using that, vitrectomy is done using the cutter and endolite. First, you do anterior vitrectomy, followed by core vitrectomy, and then the peripheral shape vitrectomy is done. And you clear the vitreous around the break. Then I'll be telling you regarding TRD. There are 2 methods of removing membrane. Mainly the delamination and segmentation method. In delamination, we use horizontal cutting scissors. Here, the membrane is cut in layer by layer in delamination, while in segmentation, the membrane is cut into small segment using vertical cutting scissors, and then it is cut by the, by the cutter. This is important. Characteristics of the break. So, type of break, a tear is more dangerous than a hole because it is associated with dynamic DR traction. Size, larger the break, more dangerous. Symptomatic tears associated with acute PVD are more dangerous than those detected on routine examination. Location, superior breaks are more dangerous than inferior. Also, equatorial breaks are more dangerous than oral because in oral breaks, they are located near the vitreous base. Pigmentation around the break indicates that it is long standing and the danger to progression is less, although chronicity is not guaranteed after against future progression. Now, vitreous substitutes which can be used. You can use intraocular gases, silicone oil, and PFCl, perfluorocarbon liquids. Intraocular gases includes non-expansile and expansile. In non-expansile, there are 3: air, SF6, and C3.
Sheetal, sorry to interrupt. You need to wind up in a minute.
Yes, sir. So I'll just like to, I have only 2 slides left. In intravitreal tamponades, you can use air, SF6 and C3F8. Air average duration is lasts for 3 days, SF6 is 12 days, and C3F8 is 38 days. SF6 doubles, it expands twice its volume, and C3F8 quadruples, and largest size is reached in 3 days. So my take-home message is peripheral fundus examination is important, especially in high myopes, other eye in patients of RD, and traumatic RD in one-eyed cases. Macula on RD should be operated early and identify and seal the break. Thank you.
Thank you very much. And Sheetal, you had included very nice images which made it self-illustrative. Over to Preetham sir for concluding remarks, Ragini madam and Lane sir, and then we take on the quiz which will be conducted by Bide sir and Anaga madam.
So, my connection was weak, so I was not there for a few minutes of the presentation. So just one aspect which I would like to mention in RD is, why does the split in the rhegmatogenous RD happen between the neurosensory retina and the retinal pigment epithelium? So that has a embryological basis, and one must remember that it is the secondary optic vesicle, the inner part of the secondary optic vesicle, and which develops into the neurosensory detachment, whereas the outer part of the secondary optic vesicle forms the retinal pigment epithelium, right? So there is a potential space between the inner and the outer layers of the secondary optic vesicle, and this is the potential space which splits or gives way and forms a rhegmatogenous RD. So this has to be kept in mind. Any other comments?
Sir, there is a question from the audience. Does the position in which the patient is being examined affect the Linkoff's rule?
Who would like to answer that, Sheetal?
So it is for shallow RD, so it should not affect the position of the patient.
No, and the fact that it is a rhegmatogenous RD, right? Rhegmatogenous
Yes.
RD rarely has shifting fluid. Shifting fluid is seen in exudative RD.
Exudative RD, yes.
So in rhegmatogenous RD, really the position will not matter as to the Linkoff's rule. It will rarely matter.
Yes.
I hope that answers the question.
Yes, sir. So, sir, should we call it a day? Last remarks from madam and sir, and then we move on to the quiz. I think it was very fruitful session and good topics on retina was covered.
Excellent topics.
Absolutely.
Very good.
I think we covered the main topics of retina today. And I am sure this will be beneficial to all the postgraduates who attended this webinar.
I agree. Congratulations to Dr. Bide Annaga, and special congratulations to Swapnesh, Dr. Preetham sir, and the Retina department of JJ. Congratulations to all the residents who presented so well. Nehal, Sheetal, Kunjal, and Shilpa. Thank you, Preetham, Ashwin, Ashish, and Saili and Ashish for guiding them. And I also agree that it was a wonderful teaching and covering a lot of basics and case presentation. So it was really, really a good initiative, Dr. Santosh Bide.
Sir wants to say something.
And it is wonderful to see so many residents attending. There are 80 people in the group who have been present. So I think congratulations to the residents who have taken active interest in joining this webinar, because it is for you.
Yeah. And madam, I think this webinar is also being recorded. So, all those people who've attended, maybe they can tell their friends that they can catch the recorded version also.
Yes, yes. So basically, so the recorded version will be there forever, and probably Swapnesh, we can put it on the BOA YouTube channel, so it is there and people can study.
Sure, madam.
Actually,
We can
kudos to
start with
Swapnesh
the
and team.
quiz. So, like Dr. Santosh Bide says, that please, this is going to be at the end of the year. If you do very well with the highest points, you are going to win a prize. And Dr. Santosh Bide will make, I'm sure as a president, he will make sure that the prize is very good.
Yes.
And Dr. Anna too.
I think it is basically for PG students. It's for them. I must thank you as well as Lahane sir for starting this. This is the first program during our tenure as a PG teaching. So thanks to you and kudos to Swapnesh.
So, Swapnesh,
and everybody.
I think he pushes us to perform. So, Swapnesh should be the one deserving the credit.
This is the man of the match, but the entire team has performed actually. So thanks. So let's move to the quiz.
Yes, sir.
Neil will share the screen, or who will share this?
Dr. Sheetal.
Yes, should I share it now?
Yeah.
So there will be 5 questions. It will be MCQs. Time given for each question will be 15 seconds. So it's a quiz on Retina. So the first question is?
Yes. So we can start the quiz.
You can start.
Now.
Yeah.
Yes.
Dr.
So
Sheetal,
first
you can start.
question 1. Which of the following complications of diabetic retinopathy are an indication for 3/4 spatula vitrectomy? First, A, non-clearing vitreous hemorrhage. B, taut posterior hyaloid phase. C, fractional RD involving macula. D, all of the above.
Has to press.
It's D.
Can the coordinator guide how are the students going to answer it? Would they type it?
It is on the screen. You have to click the option. Please do not write in the chat box. Only click on the screen, the option, the correct answer. Do not type anything in the chat box, please.
Last 10 seconds.
But Sunil, there is nothing to be clicked here on the screen.
Yeah, it came once.
It
did come once and then it went away.
Just
so
vanished.
Yeah, there was a pop-up which came up.
It was answered, sir. I'll just share the results also.
35 people are answering, I think.
The polls you can see.
So I'm just showing the correct answer also.
Correct answer is D, all of the above.
Okay.
Humble request to all participants, do not type anything in the chat box. When the quiz poll comes, just click on the right option as per your choice. Do not write anything in the chat box. Wait for the polls to be active and click on the option that you're doing. And please do not annotate, do not write, do not tick anything, do not put anything on the screen, only on the pop-up quiz, please.
Mention about the time also.
Doctor.
The one
Yes, it will be 15 seconds only.
If we have a 6th question, then we can start like that. Maybe we can use this as a trial question.
Yeah.
Next question.
Next question.
Yes. Second question.
Can you clear the annotations?
Yeah,
Do not annotate on the screen. Anybody who's ticking it, I mean the tick kar rahe hain, please do not do anything on the screen. Don't do anything on the chat box. When the pop-up comes, just click on the right option as per your knowledge. Do not write anything else anywhere else.
I'm unable to change it. Like.
Yes, actually, people just stop and reshare, doctor. Just stop and reshare. Just stop. I am just stopping.
Yes, okay. Yeah.
Now reshare. Please do not write anything on the screen. Just click on the options when it comes for voting. It will be on for 15 seconds. It will be announced. Do not write anything in the chat box. Do not write anything on the screen. You are helping others if you are putting the
The
answers in
second
chat.
question is, where is the most likely? I can't see.
Position of the
We can
retinal
see. We
layer.
can see.
Yes. What is the position of the break in the figure shown below according to Linkoff's rule? A. Inferior nasal, B. Inferior temporal, C. Superior nasal, D. Superior temporal. The shaded area represents the area of detached retina. This is the detached retina.
Launching the quiz now. Please vote on the screen when it is live. It will be on for 15 seconds. Quiz is live. Five more seconds. We'll close the quiz. Stopping the quiz. We are sharing the results.
Answer is superior nasal.
Great. Move on to the next question.
Yeah,
Yes.
next question. Yeah.
Same thing is happening again. Which of the following is not an associated risk factor for CRVO? A. Diabetes mellitus, B. High plasma viscosity due to blood dysplasia, C. Hypertension, D. Longer axial length.
Starting the quiz. Five more seconds. Stopping the quiz.
The correct answer.
You can announce the right answer.
Sheetal,
Dr.
next
Sheetal, you
question.
can announce the correct.
Please share the correct answer.
Longer axial length is the correct answer. Next question is, ETDRS is a landmark trial. It reports results on the timing of PRP in PDR and the outcome of focal laser in management of diabetic maculopathy. All of the following statements were used to define clinically significant macular edema except A. Retinal thickening at or within 500 microns of the fovea. B. Any microaneurysm or hemorrhage within 1 disc diameter of the center of fovea with associated BCV of 6/12 or worse. C. Hard exudates at or within 500 microns of the fovea if associated with adjacent retinal thickening. D. An area or areas of retinal thickening 1 disc in size, at least part of which is within 1 disc diameter of the fovea.
We are launching the quiz.
I request the participant to keep their mic on mute mode.
5 more seconds. Closing the quiz.
Correct answer is any microaneurysm or hemorrhage within 1 disc diameter of the center of fovea with associated VC-based spatter. So moving on to next question. A 34-year-old myopic female presents with worsening vision and distortion in her left eye. She has no past ocular history. Visual acuity is 82 and 49 ETDRS letters in right and left eye respectively. An OCT angiography scan is shown in the photo below of the left eye. Which treatment option would you recommend? A. Focal argon laser. B. Intravitreal aflibercept 40 mg per ml. C. Observation. D. Triamcinolone acetate. I hope
Starting the
everyone
quiz,
can
please.
see the photo. OCT angio photo.
Yes, starting the quiz. Five more seconds. Ending the poll.
So the answer is B. Intravitreal aflibercept.
Very good. Sunil, can you share the results?
Yes, the answer is B. Intravitreal aflibercept.
Now Sunil will share the results actually. Sunil, are you there?
Yes, sir. I'm just compiling.
Yeah. So till he is compiling the results, madam, can you comment on today's activity line? Ragini madam. Unmute, please unmute yourself.
So I really enjoyed the quiz, and it is really 1 hour of intensive teaching. So it will be very good for all the PTs, you know. These online sessions are very good because it can be attended by everybody all over India and all over Maharashtra. It's a very, very good initiative. And since residents are busy with their, work and all that. So they can attend class from their own boards or everywhere, which is very, very important because they cannot travel, they cannot leave their duties, they do not get that much leave to attend so many conferences and all that, like every week or something like that if there are CMEs. So this is a very, very good initiative for PGs because they get to learn from teachers, not only their own teachers, but they will get to learn from teachers all over India, Maharashtra, and they will get to interact with their colleagues. And the quiz is really good and entertaining at the end of the session. So it keeps the session very lively. So this is, I am also enjoying the quiz, frankly speaking.
Yeah. Actually, more and more PGs should attend. I think we need to promote more.
So today, I think the attendance is very good.
Today
I
was
have,
good. Still
I have 14 new PGs who joined today, but probably they were not aware. So otherwise, I think the score would have been 100. So next time we'll ensure that the score is 100.
It was 102. Then
Achha?
somehow, yeah, at one point it was 102.
So that is
maybe
really very nice.
It will be more, maybe 150 or maybe 200 also.
If there is a YouTube link, once this is recorded, we should put it on our YouTube and then we can share it with many more PGs.
Yes, it will be, it is recorded actually, so we will do that. Sunil, are you ready with the results?
Sir, it will take time. Can we announce later? It will take around 15-20 minutes to compile because it's a private table.
No problem.
We can announce
Thanks.
the results of this quiz during the next session.
Yes, that's a very good idea actually. Next session is on.
Attend the next class too.
Yes. Yeah, correct. So Swapnesh.
Thank you, madam.
Swapnesh. Yeah, that's a
Yes,
very
sir.
good idea.
Thank you,
We'll
sir.
announce these results in the next session, which is there on 21st of December, same time, in next to next Wednesday. Again, the topic is retina only, and it is by JJ Hospital and Grand Medical College. So, Swapnesh, are you there?
Yes, sir.
Please, now you can sum up and
Yes,
end the
so I think it was a
Thanks a
wonderful
lot.
session. All the important topics of retina was covered, and thank you, Ragini madam and Lane sir, for giving us an auspicious beginning by having JJ Hospital team with us and the residents. And thank you once again, Bide sir and Annaga madam, for this chance. After 2 weeks, same Wednesday 8 to 9, we will have one more medical college presenting some more new cases on retina, some more interesting cases and discussions. So good night and see you all. And with permission from all the seniors, I'll send a goodbye.
Bye, good night, and thank you everyone.
Good. Thanks.
Thank you
Thanks,
very
Swapnesh.
much. Thank you
It was
very much,
really
Rani
great.
sir, Ragini ma'am, Dr. Sapnesh, Dr. Preetham, Dr. Saili, all the speakers, all the participants. Excellent program and very, very informative. Looking forward to many more such. Lot of efforts. Appreciate all your efforts. Thank you very much.
Thank you so much.
Great.